Okay, welcome to today's webinar. This is now an annual laser therapy research year end review that I've been doing now. So obviously we're in 2022, thank goodness. And I want to thank everyone for joining myself and Dr. Randy Santiago, who I'll bring in shortly. You may have seen him pop up a little bit earlier. So a little bit of housekeeping. Today's webinar, as all my webinars are recorded, and that means that we edit them, excuse me, and then we upload them onto our website. But before that, you'll actually get a follow-up webinar a follow-up email with a link to the webinar so that you can watch that as well. So all future webinars, as long as you register for it, even if you don't attend, you'll still get that email. And if you don't do that, you can still actually find it on our website. And I'll kind of walk you through how to find that as well too, if I have a chance. So just waiting for a few more people to log in here to today's webinar. If you're new to this, my name is Dr. David Kanashko. I'm the medical director at BioFlex Laser Therapy based out of Toronto, Ontario, Canada. And we're manufacturers of photobiomodulation devices. Of course, we use the term laser therapy, but that's not overly accurate, but it's the one that everyone seems to gravitate towards. And so I'm a chiropractor. Dr. Randy Santiago is an ophthalmologist. He's the doctor that's involved with all of our ongoing clinical trials. So I think you'll find his information very interesting, not just what he presents as far as what's been published, but also maybe a bit of our ongoing research as well. All right, so if you haven't joined in, I guess you'll be joining in as we go along. So I'm going to just talk a little bit about the stats for 2022 with respect to peer-reviewed published research. And even before I get into PBMT or photobiomodulation therapy research, I will mention a couple of research papers that are quite relevant with respect to clinicians and how they deal with pain. So even though these aren't directly related to photobiomodulation, well, one is kind of indirectly, it is quite groundbreaking research and or evidence-based guidelines that I think everyone should know as a clinician. Today's webinar is geared more towards clinicians, but of course, you know, it's open up to anyone that cares to watch. And then myself and Randy will go over some of this fascinating, interesting research that was published in the year 2022, and I'm sure we'll have time for some questions and answers. And just so you know, this is a little bit longer than a typical 30-minute webinar. I'm sure we'll be pushing past 1 o'clock. I'm not sure how far past that. It all depends on how much Randy talks, but we shall see about that, or myself for that matter. All right, so let's take a look at the results. And I use PubMed. I mean, there's other search engines, but PubMed is the one that tends to be used the most. So when you type in the acronyms PBMT, because of course that's the one that's being used a little bit more now in research, along with the older term or acronym low-level laser or low-level light therapy or LLLT, that pulls you up most of the research. I mean, you can put some other acronyms or points in there to maybe pull up a few more, but in general, that should encompass all of it. And if you look at this particular year, of course, it's not quite done yet, but we're at about 495 research papers. I'm sure it'll be well over 500 by the year's end as well. So not a bad year. Some years have actually been more, up to 700 plus. So maybe a little bit down this year, you know, still I think having the effects of COVID and some other issues, especially for clinical trials. So that's kind of slowed things down a bit, but nonetheless, there's been lots of really fascinating research. By the way, if you have any questions as we go along, type them in the Q&A box, the chat box. Someone made a good point about me having to update something, so maybe I'll try that before I do my next webinar. I would think these things will be automatic, but apparently not. So let's move forward. One paper that, well, actually it's not a paper, it's evidence-based guidelines. And it was published very recently in November of this year by the CDC, or the Centers for Disease Control and Prevention. Of course, this is an American or United States-based think tank. but it's kind of what the world looks to for the most part, because they're going to be looking at all of the evidence and make recommendations based on that. And of course, they're a big organization, so they tend to have a lot of weight out there. And this particular one was on practice guidelines for prescribing opioids for pain in the United States. So it's geared towards physicians, but it's interesting because a lot of us who are not physicians deal with patients in pain all the time. So they come to us for, ways of dealing with pain that aren't, a medication, right? So what they recommended in their guidelines was non-opioid therapies are preferred for subacute and chronic pain. So although they still saying you can prescribe opioids for acute pain, they did make very specific limitations around that as far as how long and so forth. But the key thing here is that they're really trying to tell the physicians, don't be prescribing opioids as a patient's getting better or subacutely, and certainly not for chronic pain, because then you open up the whole, downward slide for addictions to opioids. And now they mentioned lots of different kind of, conditions, but specifically low back pain being one of the most common causes of acute, subacute, and of course, chronic low back pain. They made some recommendations for physicians as what they should be recommending to their patients, as opposed to just writing that prescription for subacute and for chronic pain. And for low back pain, they recommended, now remember, these are evidence-based recommendations. In other words, based on clinical trials, meta-analyses, systematic reviews. And for low back pain, you can see low-level laser therapy. Of course, they haven't caught on to the new name. Low-level laser therapy was recommended along with spinal manipulation, massage, mindfulness-based stress reduction, yoga, acupuncture, and multidisciplinary and rehabilitation. So a couple key points here is that they weren't specifically calling out, shockwave or ultrasound or, modalities per se. The only thing they actually did with respect to modality is mention low-level laser therapy, which is quite interesting. And that means that there's a fairly significant number of positive studies of good statistical evidence that is quite effective, right? And that's why it's in there. So that's why you're not seeing Dr. Ho and his TENS machine and shockwave and, all these different devices out there that potentially can be used, along with obviously what we know works quite well as practitioners, and that's typically things like yoga and things like active therapies and manipulation and massage and all these different things that we know are effective for our patients. So I thought this was really interesting and something that everyone should realize has been published, and the gain of laser therapy in the eyes of standardized Western medicine, of course, being in the United States. Now, this next paper I find very fascinating. I commented on this one earlier in the year, but I want to bring it back because it's really significant. In part published by McGill University, of course, that's out of Montreal, and it was published in Science Translational Medicine, which is a branch of Science journal, which, if you know journal science, it has one of the highest impact factors out there, a really key journal. So it's called Acute Inflammatory Response via Neutrophil Activation Protects Against the Development of Chronic Pain. It's quite a handful, but the key things here, and I have a few slides, but I want everyone to understand the ramifications of this paper and how important it is when we're talking about patients that, are going to be taking NSAIDs, Aleve, and, all these different over-the-counter, along with prescription ones that, as it turns out, are definitely not the way to go. So we know that chronic pain inflicts a huge cost in society. Low back pain, of course, is one of the most frequently reported chronic pain conditions. Worldwide, the prevalence for 1 month, so in any given month, 31% of people are walking around with back pain, including myself today. Woke up the other day with back pain. And I tell you that if you, one of the keys for back pain is keeping active. If you just sit around and don't do anything, it will prolong. So keeping active is key. And 1 year is 38%. At any given time in 1 year, 38% of the population are suffering from chronic low back pain. Really high numbers, right? So it ranks amongst the highest of chronic conditions lived with disability. It causes lots of disability. I mean, people can't work. They can't do their activities of daily living. All these different things that we need to function with our back, we can't do. So it has a really high burden, and this burden increases with age. So very little is understood about the actual mechanisms underlying acute to chronic pain transition. And so there is increasing evidence that the pathophysiology of chronic pain is quite a complex interplay between the nervous system and the immune systems. So in other words, chronic pain, they feel, is a neuroinflammatory disorder mediated by neuronal and non-neuronal cells alike. So understanding this is really important. And part of the understanding of this is that circulating immune cells, neutrophils, monocytes, T cells that are initially recruited to the site of tissue damage. So, you pull your back, you strain a muscle, and it initiates inflammation. But what happens is these cells can infiltrate the peripheral and central nervous systems. And the activation of these cells results in expression of various inflammatory mediators. We've talked about these in the past, cytokines and chemokines and, all these things I'm sure you're aware of. And they can act both directly and on the peripheral sensory or central second order neurons, and indirectly on other immune or local cells to regulate pain. In the central nervous system, microglia and astrocytes act in a similar fashion and contribute to what's referred to as central sensitization and pain. So this is literally, someone has chronic pain, they appear fine, you can't figure out the source of that pain, but they have chronic pain. And that's the central sensitization that's going on in the central nervous system. And that by far is the most challenging type of scenario to resolve. So the presence of these activated immune cells and glial cells peripherally or centrally is thought to contribute to transition from the acute to the chronic stage of pain. So the research involved was quite sophisticated, and they used molecular pathophysiological mechanisms. They investigated them on peripheral blood immune cells that underline this transition and identified the protective effect of acute inflammatory responses against the development of chronic pain. So they replicated these findings in two types of pain. One was low back pain and one was temporomandibular disorder pain. And the results that they found was that active inflammatory responses, particularly those of neutrophils, contribute to pain resolution. In other words, they hypothesized that the inhibition of this active immune response will lead to prolongation of pain. Okay, so what does all this mean, right? It means that if you block the pathway, the normal physiological pathway in your body to resolve acute pain, i.e. NSAIDs, then this will actually cause a problem and will lead to prolonged pain and potentially to chronic pain. So in their studies, they found that individuals, so this was done with people with back pain and TMD pain. And they went to see, how many of those patients went on to a chronic pain and relating to ones that took NSAIDs. And they found that there's almost a twofold greater risk of developing chronic back pain if they reported NSAID usage than if they were not taking NSAIDs, and they adjusted for age and sex and ethnicity and time interval between measurements. So their data suggests that active biological processes protect from transitioning to chronic pain after an acute pain episode. In other words, you want to support your patient and help them resolve the acute pain without blocking it with a medication. And that's what many of us that are listening in, whether I'm a chiropractor, whether you're a physiotherapist or massage therapist or whatever profession, that's oftentimes is what we're trying to do, right? So they found that neutrophil activation dependent elevation of the inflammatory response at the acute stage of pain in subjects with resolved pain which was decreased by the time of the second visit. Conversely, subjects with persistent pain did not show any changes in the inflammatory response. So in other words, when you block the inflammatory response, then this causes persistent pain. So the research suggests that active immune processes confer adaptation at the acute pain stage, and impairment of such inflammatory responses, that is a prolonged use of NSAIDs in subjects with acute low back pain or temporomandibular, those are the two ones they looked at, increase the risk of developing chronic pain. So imagine if they put a little warning on a leaf that said, if you take this drug, you increase the risk of developing chronic pain. Wouldn't that be nice to see on some of these labels, right? So despite the analgesic efficacy at early time points when you're taking NSAIDs, management of acute inflammation may be counterproductive for long-term outcomes of low back pain and obviously other painful condition in patients. So the takeaway here is that photobiomodulation is known to directly affect the resolution of neutrophil influx and accelerate the inflammatory pathway, including greater activity of the numbers and activities of macrophages that hasten the resolution of the normal inflammatory pathway. So really what it's doing is it's shrinking the inflammatory pathway, but not blocking it like an NSAID. Remember, this is photobiomodulation, not inhibition photobiomodulation. Inhibition is where you use really high powers of light to block pain pathways, which is done in a different way. However, the idea here is that we're actually trying to resolve the inflammation. And by doing that, you need to have the light be absorbed by neutrophils and macrophages and stem cells and the immune system. So NSAIDs may mask pain temporarily, but may actually increase the probability that your patient will develop long-lasting chronic pain. Okay, so I thought those two papers were really important that were published this year, so I'm hoping that you also find them interesting and perhaps can share that with your patients and perhaps and referring doctors as well. This next paper, let's looking at the time here, well, it's 12:30, I haven't even gotten to photobiomodulation. Randy's probably fallen asleep over there. So this next published paper was the efficacy of low-level laser therapy in patients with lower extremity tendinopathy or plantar fasciitis. It was a systematic review and meta-analysis. So that's what they were basically doing. They looked at, I'm just going to put this over here. They looked only at randomized control trials, and it was either lower extremity tendinopathies, typically Achilles, and plantar fasciitis. And so they found 10 trials, actually a total of 10 placebo trials and some other trials as well. And what they found was that pain was significantly reduced with laser therapy once they completed their therapy and 4 to 12 weeks later. So it was a long-lasting effect, not just a temporary effect. And also what's really important is disability was significantly reduced after completed therapy as well. So they recommended the recommended doses used in those particular trials significantly reduced pain as an add-on to exercise therapy versus exercise therapy alone at completed therapy and up to 4 to 9 weeks later. And again, no adverse events were reported. So they concluded that laser therapy significantly reduces pain and disability in lower extremity tendinopathy and plantar fasciitis, both in short and medium term. Next paper, photobiomodulation therapy in mood disorders. Again, a systematic review. So they looked to see what's been published to date, and they wanted to see if there's any, evidence that PBMT might be helpful for mood disorders. And now there's not a lot yet. There's 16 studies, only 4 RCTs. So this is still pretty early on. But for the most part, the studies used near infrared, 800 to 830. You can see the power that they were using or the energy density. And what they concluded was that based on these trials, that PBMT can be classified as strongly recommended for moderate grade of major depressive disorder and recommended for anxiety disorder. So that I found that pretty interesting. In bipolar disorder, there's not much research, and they basically saying they need to do further research on that. Next paper was on the effectiveness of laser therapy and therapeutic ultrasound in the management of temporomandibular disorders. Again, a systematic review and meta-analysis. So they looked to see for the reduction of pain, muscle tenderness, joint clicking, all the things we associate with TMD. And they compared laser therapy to TENS and therapeutic ultrasound in these patients. And they looked at 12 RCTs. What they found was that in the systematic review and meta-analysis, comparing the effectiveness of LLLT, TENS, and therapeutic ultrasound, that laser therapy provided relatively more effective pain relief and improvement in mouth opening compared to those other quite commonly used therapeutic modalities. Next paper was the effectiveness of low-level laser therapy in patients with discogenic lumbar radiculopathy. This was a double-blinded randomized control trial. It was done out of Pakistan, 110 patients. They were split up into a couple of groups, I believe here, with a mean age of 38. And you can see they tested for everything from visual analog, pain scale, functional disability, Oswestry disability index, the inclinometer to measure range of motion, and straight leg raise test. They had two groups, Group A, Group B. Group A was the laser therapy and conventional physical therapy. Group B was just conventional therapy alone. The parameters, 830 nanometers. You'll see this a lot. This is what we use as well in BioFlex, is 830. It tends to be a very good wavelength for getting as deep as possible. So it makes sense if you're treating low back pain and discogenic for that matter, to get the light as deep as possible. 100 milliwatts, again, that's usually what you're looking at, usually between 50 milliwatts and 200 milliwatts is what you tend to see. And then you can see the number of joules per point or energy density. And in this case, they use 100 milliwatts, 30 seconds per point, giving 12 joules per point. And here are the results. So you kind of have to look at them carefully. It's not a crazy difference, but there's a statistical difference. On the left here, the two bars, the green represents the VAS or pain 7 out of 10 scale when they first started. And then when they finished, remember this is laser and exercises, it went down to 1. Correspondingly, just with exercises alone, it went down to a 2. Okay, so still helpful, but you throw in laser, you get even better result. And then similarly, they looked at the Oswestry index as well. So, the lower the better there. The lower the better. So you can see it went down to 17 for laser and exercises and down to 21 for just exercises. Again, significantly better when you combine the two. And again, it just makes sense. You're going to usually be doing laser therapy along with other things, right? So, but it just shows you that when you add laser to the normal things that you do, your results will be better. That also shows better lumbar flexion from 47 to 43, and lumbar extension to 18 as opposed to 13, right? So again, they concluded that laser therapy is an efficient adjunct therapy for discogenic lumbar radiculopathy. Next paper was on pain and disability of conservatively treated distal radius fracture. It was a triple-blinded randomized placebo-controlled trial of photobiomodulation therapy. The reason why they're using the right term is that it was in part done by Jan Bjordal, who's a physiotherapist, I believe, PhD, but one of the world-renowned experts in photobiomodulation. He does a lot of publications in the physiotherapy realm, and he knows what he's talking about. So obviously, it was looking to see if photobiomodulation applied after cast removal provides an add-on effect to home-based exercise program for distal radial fractures. It was a triple-blinded placebo-controlled trial. 50 patients were conservatively treated with randomized to receive either PBMT or placebo PBMT. They also did questionnaires and all the things that you would expect. And they were evaluated after cast removal so that was baseline, then 4 weeks, 8 weeks, 12 weeks, 26 weeks after the injury. And they had 9 sessions of either active photobiomodulation therapy or placebo over 3 weeks in addition to home exercises. the irradiation of the fractured area. So they actually took x-rays to make sure they exactly knew where the fractured area was. And it's performed both on the dorsal side of the fracture area and on the palmar side. So it's important when you're treating fractures, you treat all the way around the bone. So that's another good tip or point I should add. Laser diodes contacted the skin. Okay, I always harp on this because it slightly annoys me when people talk about wanting to get laser therapy equipment that's not held on the skin. Erconia, what comes to mind, because it nearly all research, published research, it touches the skin. It has to, because you want light to penetrate into the skin. And they actually used 3 points. Each point received 1.2 joules, daily dosage of 7.2 joules, 9 sessions in total. So the result was a significant between group difference between these groups. And they found overall that PBMT is safe. It has long-term positive effect on pain and disability when applied in combination with home-based rehabilitation. So it was more effective than just exercises alone. I didn't go into a lot of detail with that one because there's so much research out there and I only have so much time. Okay, next one is treatment of carpal tunnel syndrome. And this was really interesting because they compared cortisone injection, a corticosteroid, to laser therapy. And I thought that was quite fascinating. So there was 143 wrists used in this trial, diagnosed with moderate CTS, and they were randomized to either cortisone injection or the laser therapy group. So 44 patients, some of them had bilateral, so it was 74 wrists. Laser therapy was applied to 43 patients, 70 wrists, 5 times a week for a total of 15 sessions. And you can see here, again, notice 830 nanometers, ring a bell, right? Infrared, get into the bone. So they looked at numbness and pain and quick dash questionnaire, grasping tests, Tinel and Phelan's tests, MRI. So it was quite an extensive testing. And 80 patients completed the study at the end of the 6 months, 133 wrists. VAS and quick dash scores were better in the corticosteroid group in the first month, but then there was no significant difference between the groups in the 6th month. In other words, that laser therapy took a little bit longer to catch on, but then the results were the same. So Phelan and Tinel's tests, the strength tests, and the motor distal latency improved significantly in both groups, first month and 6 months in. So in both groups, the median nerve intensity rate and pulmonary spring rate, I don't even know what that is, improved significantly after treatment. So based on this study, cortisone injection and laser therapy groups showed statistically significant difference at first month, whereas there was no significant difference at the 6th month immediate term. So, well, as we know, cortisone injection is going to have a quick, immediate response, but it can be damaging, right? And probably not the best because it's invasive as well. And it's highly selective as far as whether it's done, the injection site's done correctly and all these different parameters, risk of infection, side effects, all these different things. Long-term, if you do laser therapy, the results are the same. So why wouldn't you choose laser therapy? I think this is my last study. Maybe not. So Randy, pay attention here. So this is immediate effects of photobiomodulation on maximum lip pressure. And I looked at this paper, go, maximum lip pressure? Why? Why would they do this? And then I started to read the paper and I understood. I'm not a speech pathologist, but as you probably know, people recovering from strokes that have other issues with articulating and using their lips to speak. So in speech therapy and occupational therapy, this comes up all the time, right? So that's why this is a really important paper. So among the orofacial muscles, the orbicularis oris, obviously, which constitutes the lips, is really important for enunciating and chewing and swallowing and breathing and all the rest of it, right? So alterations in the muscular tension can trigger problems, including slurred speech and difficulties chewing and talking and all these different things as well. So what they did here was, it was an experimental randomized triple-blinded study, 23 women, 17 men between 18 and 33, distributed into 4 groups. And it was interesting because in these 4 groups, they used different dosaging, and they tested for and used the Iowa Oral Performance Instrument. I'll show you what this is. And that's how they tested the strength. And as I mentioned, they did a few different dosage, 1 joule, 4 joules, and 7 joules. And look at the wavelength 808. So again, low 800s is typically what you're going to use to penetrate into muscle tissue. And they applied it at 6 points around the orbicularis oris muscle. And in the CG or control group, there was no intervention or a placebo one. This is what the device looks like. You purse your lips and push down, and I guess it measures the contraction of the orbicularis oris, which you probably all are aware. It's a circular muscle around your lips. And here are the points that they treated with, in this case, laser. Now, I didn't put this in the my comments, but at the very end, the authors did say that LEDs more than likely could also be used for this as well, which would be a little bit safer and easier to do, especially for at home. But they didn't investigate the LEDs. So the evaluation, again, used laser, and the results were analyzed with significance level of 95%, so statistically relevant. The maximum lip pressure increased significantly only in the group with 7 joules of energy. So remember, or maybe this is new to you, is that photobiomodulation tends only to work in what's referred to as a biphasic dose response. So there has to be enough dosage into the tissue that you're trying to treat to get the effect. In this case, we're trying to improve muscle contraction, right? And so that means that the dosage has to be high enough at the level of the skin to allow enough light to penetrate and accumulate into, this case, muscle tissue. Even though you think it's superficial, it is a superficial muscle, but you still have to get through skin. So, and deep to that. And so that means that you need a bit more energy at the surface of the skin. And that's why they found the 7 joules was more effective. So the conclusion was low-level laser therapy with 7 joules promoted changes in the performance of the orbicularis oris muscle in the maximum pressure task. So it's one of these tools that perhaps they can start using for these types of patients. This could be my last paper, Randy. So the effects of low-level laser therapy on muscular performance and soreness recovery in athletes. Again, a meta-analysis and randomized control trial. The whole idea here is that we've heard a lot about using laser therapy for muscle performance and like delayed onset muscle soreness. And we, these papers that keep being published for the most part are pretty positive. So when we see meta-analysis, it's a bit more powerful paper to look at. And the results looked at 24 studies. And they obviously used laser therapy or low-level laser therapy, not just lasers, but LEDs as well. And they looked to see if it helped with improved lower limb muscle strength, 24 hours, 48 hours, 96 hours, 8-week follow-up groups. And they used, decreased soreness index. Sometimes they measured serum creatinine kinase, interleukin-6, other things, and even did VO2. So they did a lot in these studies, and they concluded that the dosaging is still not yet established, but the current evidence supports that low-level laser therapy improves muscular performance in physically active athletes. Additional trials with larger sample size and robust design should be conducted before strong recommendations are made. But this is just showing you the trend. And usually, we start using it before, they have a definitive kind of, evidence-based guideline, but it's definitely getting there. Within the next year or two, you will see really firm evidence-based guidelines based on the research. Okay, so look who's coming up right now. It's Randy. So I'm going to have Randy share his screen. There you go.
Where did you get that picture?
Oh, I found it. A little bit of payback for you. So you can share your screen. Those of you who don't know Dr. Randy Santiago, he is a medical doctor, an ophthalmologist, and is our medical director of clinical research. Are you sharing your screen?
I am sharing my screen.
Oh, can you put your presentation on?
There.
There we go. And yeah, full screen. So we're now starting to be a lot more involved in clinical trials, and Randy's involved with this. So I'll shut up and I'll let Randy get to work.
Oh, hi, folks. So I put here end of the year weird stuff per recommendation of David. He gave me a bunch of articles that he'd like me to talk about. I added a few more that I feel are interconnected. Anyway, I'll discuss a few of some of these interesting research articles from last year with the goal of always use your intellect and minds when discerning anything you hear or read. I would still rather trust peer-reviewed articles rather than social media hype, which unfortunately is where everyone receives their info these days. But you still need to keep an open mind, but keep being inquisitive. And really, if anything is too good to be true, it probably is. I will again quote Dr. Michael Hamblin, who mentioned that the PBM industry is its own worst enemy. Let's start first with the first study. This is photobiomodulation therapy for the treatment of olfactory and taste dysfunction, COVID-19 related, a case report. So this is a 34-year-old female who was COVID positive a year earlier with only mild symptoms, but whose main complaint is loss of taste and loss of smell. The treatment they provided for the loss of smell, they used lasers for both conditions. Take note of the dosages, 30 joules for each nostril. For the loss of taste, they used a showerhead type of laser device that used 3 lasers of red 660 and 3 lasers of infrared 808 nanometers. The total energy delivered here is almost 682 joules per square centimeters. That's a lot. And 10 sessions were performed over 25 days. Here's an image of how they provided the treatment. So 3 placements of the laser probe for the mouth here, and 1 for each nostril. The results, they unfortunately just used a modified visual analog scale. Instead of using it for pain, they used it for taste and smell. And that unfortunately is not validated. But the patient gave a score of 4 for taste and smell before the start of the treatment, and then claims she has a score of 10 after the 10th session. So during the discussion, they were saying what potentially have caused the loss of taste and smell. They were thinking maybe an inflammatory cytokine storm, maybe actual viral damage to the cells of the oral cavity and respiratory epithelial cells, or maybe lesions in the peripheral nervous system caused this. And then they tried to give an explanation as to how photobiomodulation improved this patient's condition. They're thinking maybe PBMT provided neuroprotection through anti-inflammatory and antioxidant pathways, or maybe there's an increase in the number of salivary ducts and mitosis of epithelial cells. And they were wondering maybe photobiomodulation promoted the metabolic hemostasis necessary for the restoration of olfactory and gustatory sensory function. All of these are all questions. I can't vouch for why they think this worked for this specific patient versus probably just waiting for a month to see if her sense of taste or smell came back. But I do have a lot of questions regarding the dosages. Just to let you know, I do use these large dosages myself. But as David said, mostly for inhibitory purposes, especially for pain or for analgesia. But here they use it for stimulatory doses. So we don't know if these large dosages actually helped in improving their loss of taste and smell. And of course, we need more studies to confirm this. The second study is the therapeutic potential of photobiomodulation for chronic kidney disease. This was given to me by David. Unfortunately, there wasn't much explanation on how this would potentially affect kidney disease. They just gave potential causes of improvement, but there wasn't any specific examples of suggested dosages, and we already know all these things. So I won't go a step further. They should probably do a clinical trial next. The next study is called Mitochondrial Photobiomodulation as a Neurotherapeutic Strategy for Epilepsy. Full disclosure, this article references studies on 2 types of rats, but they're still rats. There's a big difference between treating a rat versus treating a person. So the 2 studies involve 2 different types of rats.
No, sometimes I think rats and humans are pretty similar.
I agree. I'll show you why later. Two studies. The first one uses lasers, continuous wave. Again, take note at the fluence, 133 joules per square centimeters. That's a lot compared to what Walt recommends, which is 4 to 10 joules. And I'll explain in the other studies later why that's the case. The second one uses light emitting diodes, your arrays. And this uses the more common fluence of 10 joules per square centimeters. They both showed that there's an attenuation of the mean seizure score and reduce the incidence of status epilepticus and mortality. So thoughts. Although there's the possibility that photobiomodulation could potentially trigger epileptic seizures, there is no evidence in support of this. And the two studies evaluating PBM effects on seizure models have found that photobiomodulation reduces seizures. Or does it? I don't have suspenseful music. Sorry, I don't have the funds for that. Their explanation was transcranial photobiomodulation may treat the mitochondrial dysfunction in epilepsy by upregulating cytochrome C oxidase, which is the terminal enzyme in mitochondrial respiration. This mitochondrial mechanism of action of PBM might benefit epilepsy because transcranial photobiomodulation is neuroprotective and improves human neurocognitive functions affected by epilepsy. And of course, more studies need to be done. I felt like that was a shallow explanation of what happened. I put this picture here because I needed to show to you how this would be equivalent to a human head. In order to put a laser diode that big in a human head would entail an aperture the size of a bucket. So I felt like the amount of dosages they used for this specific study was a bit too high. They did not do an autopsy on the mice to see how it affected the brain structure. For all I know, it fried their brain structure. So they nailed it with this comment at the end. Evidence regarding mitochondrial functions is still lacking. So personally, I probably wouldn't do this yet on seizure disorder patients. The next one is a perspective on the potential of opsins as an integral mechanism of photobiomodulation. It's not just the eyes. And I partnered that with another journal, Photobiomodulation Therapy Mechanism Beyond Cytochrome C Oxidase. I mentioned these two studies because one, they both involve PBMT's most valuable player, Dr. Ann Liebert. And it shows the current trend these days of looking at other potential explanations for photobiomodulation. We have all been told since biblical times that photobiomodulation is due to the effect of light on mitochondrial health, cytochrome C oxidase, and the increased production of adenosine triphosphate, blah, blah, blah. Based on what we've discovered these days, it seems that is what Dr. Daniel Johnstone once said in our this year's masterclass, that it's a bit reductive. That theory might explain photobiomodulation effects on a wound, but it doesn't fully explain the myriad of effects of photobiomodulation on other systems, specifically neurological disorders, as well as the various questions that we regularly receive here in the clinic. Like I heard it works on fertility, or it works on the lungs, or it makes me smarter, or increases my penis size, whatever. But there are other potential effects of photobiomodulation, probably not connected to cytochrome C oxidase. So I'm introducing here porphyrins, which are molecules called the pigments of life. They have very large absorption peaks in the blue region of the spectrum, but also have high absorption peaks in red and green regions. Cytochrome C oxidase itself is a porphyrin and is an attractive hypothesis for photobiomodulation, but as the authors noted, it's very difficult to confirm. Some studies have shown effects of photobiomodulation in cells with defective CCO, cytochrome C oxidase. And red blood cells have no mitochondria, but plasma occasionally contains cell-free mitochondria with no functional electron transport chain effect. And yet photobiomodulation still has an effect on these tissues. So could be that there might be other potential avenues for photobiomodulation to work, and not just your standard cytochrome C oxidase producing adenosine triphosphate. Opsins are ancient proteins with 7 alpha helical domains embedded in membranes with a lysine residue, bound to a non-protein retinol or light-reactive chromophore. Pbmt may involve the participation of these opsins and other non-mitochondrial membrane-associated molecules and structures. I'm giving you 4 opsin samples here, but because of time constraints, I won't discuss them that much. Suffice it to say that most of these opsins are present in a lot of urological tissues, and they are very reactive to the shorter wavelengths of light, specifically blue, green, and short ultraviolet. And let's just say some of them have some functions related to photobiomodulation that is certainly worth investigating. Other molecules that those 2 journals mentioned included ion channels, or calcium, potassium, and sodium ion channels that are responsible for nerve conduction. They hypothesize that they're also responsive to light. That's why there are some researchers who value the use of pulsating light for treatment, because they claim it's the ion channels that are being affected here. Transforming growth factor beta, I'll mention a little bit on that later once we go into the reactive oxygen species. They're claiming that other organelles in your cells, like your endoplasmic reticulum, responsible for production of protein, and lysosomes, which are responsible for intake of dangerous toxins in your cells, are also responsive to light. And finally, a new term that Dr. Michael Hamblin is using these days, autofluorescence. He calls these biophotons, or internal photon production transmission. If you have coral reefs, or if you've been to an aquarium, you'll notice that if they shine blue, actinic, or ultraviolet light on a reef tank, some of these corals glow red. And Dr. Hamblin's theory is the light that we're using can actually produce more photons inside our systems. And that is the reason why even just superficial application of light might produce autofluorescence in some of our cells and eventually cascade down to deeper tissues. So aside from cytochrome C oxidase, are there other explanations for photobiomodulation? The main highlight these days is nitric oxide production. Everyone has shown that photobiomodulation increases nitric oxide production. The question is, where is it coming from? Is it coming only from the unbinding of nitric oxide from cytochrome C oxidase? Or they're saying that your mitochondria actually produces its own nitric oxide synthase, or nitric oxide. Just to let you know, cyanide is an inhibitory molecule for cytochrome, or for complex 4, which is cytochrome C. And the treatment for that is sodium nitrite, which eventually forms nitric oxide. So they're saying that it's probably more nitric oxide as the main event that happens in photobiomodulation, more than the production of adenosine triphosphate. The other explanation they're making is for exclusion zone water. If you look at this membrane, they're saying photobiomodulation using the higher wavelengths of light, like 940 and above, causes this exclusion zone water, which is usually a bit viscous, to become less viscous. And by becoming less viscous, there's an improvement in the flow of hydrogens towards your intermembrane space, more flow of electrons. And here you have the motor that is ATP synthase that produces adenosine triphosphate can revolve faster and produce more ATP. They're also thinking about the transient potential receptor ion channels, or sodium potassium ion channels here, that they say could also act as sensors for stimulus. And finally, aside from nitric oxide, there's reactive oxygen species, which is always a byproduct of photobiomodulation. They can be increased or decreased by photobiomodulation. There's a typical small burst that occurs here, the production of electrons during the electron transport chain. But oxidative stress causes an increase in membrane potential, leading to a decrease in these reactive oxygen species. So any sudden bursts of ROS without increasing too much can cause a latency cleaving of peptide-producing transforming growth factor beta, which I mentioned here earlier. And then there's a cascade of reactions that lead to a lot of the effects that we're observing. They gave us this diagram of potential what could be the effect of photobiomodulation. As you see, here is your typical cytochrome C oxidase theory, just a small portion of what could now be considered other, or is being considered as other potential mechanisms of action of photobiomodulation therapy. The next study is photobiomodulation therapy in the lymphatic system, promising applications for augmenting the brain lymphatic drainage system. There's a diagram here of where the brain lymphatics are. There actually is no brain lymphatics. The origin of lymphatic lymph in all tissues is in your interstitial space, in between your cells. But the brain has no actual lymph vessels. Usually in tissues in other parts of your body, production of lymph in your interstitial cells is eventually drained by your cervical lymph nodes, or I mean your lymph nodes, not your cervical lymph nodes, your lymph nodes in general. But since the brain doesn't have that, they came up with this term, the glymphatic system, which is your glia, the cells that support your neurons, actually functions as your lymphatics, or the brain's way of removing waste and toxins, using a specific molecule called aquaporin 4, which improves the increase in the interstitial fluid and eventually drainage of a lot of the toxins in your brain into this part, which is your meningeal lymph vessels. The absence of conventional lymphatic vasculature in the CNS prompted a series of studies on rodents and human brains, identifying the meningeal lymphatic vessels as the main lymphatic system of the CNS. They've observed that sleep is the primary driver of lymphatic clearance. Interstitial fluid, which is where your lymph comes from, increases fastest during non-REM sleep, guided by that molecule aquaporin 4. Increased interstitial fluid leads to faster removal of wastes like lactic acid and amyloid, responsible for your Alzheimer's disease, as well as tau level proteins, which increases with sleep deprivation. Sleep deprivation increases levels of pro-inflammatory mediators, increasing permeability of the blood-brain barrier. So what are the potential effects of photobiomodulation on your lymphatics? They mentioned that your standard run-of-the-mill cytochrome C oxidase production of ATP, which, as we've discussed earlier, is probably not the only effect of photobiomodulation. They mentioned maybe the modulation of signaling molecules like your ion transport channels, reactive oxygen species, and nitric oxide. They mentioned the change in intracellular redox potential, as well as the activation of transcription factors like your transforming factor, growth factor beta, and gene expression. And they mentioned specifically targeted nitric oxide. Does this increased blood flow arise from photobiomodulation mediated production of nitric oxide? Or is it that nitric oxide is actually photodissociated by light from hemoglobin in circulating RBCs? Remember what I mentioned earlier, that red blood cells do not have mitochondria. So they're thinking it's actually nitric oxide being released from red blood cells, not necessarily from mitochondria, that is causing the effects of photobiomodulation. They also mentioned these pathways. These are a bit too deep for my pay scale myself. They involve a lot of biochemical molecules that increase neuron survival. And they noted that pulsing light using the higher wavelengths has also been reported to decrease cerebral amyloid beta levels due to increase in cerebral vessel density. And they noted the use of intranasal and systemic photobiomodulation therapies. Let's go with nasal first. It is postulated that systemic effects on hematologic blood cells, or cells in the blood, would contribute to the effects reported by intranasal PBM techniques. I'm sure you've heard of several device manufacturers who put the devices inside the nose itself for the purpose of reaching the midbrain. They're thinking that it's actually because of photobiomodulation only on the blood. It doesn't actually reach the brain, and the release of nitric oxide from the blood vessels are the ones that have their effect. And the possibility that photobiomodulation therapy targeted at remote tissue like abdominal tissue might elicit systemic mechanisms that provide neuroprotection to the brain. I'll go into that a bit later in this slide. They did a test on mice. They applied a high wavelength laser, 1268 nanometer laser, using a very high amount of power, 32 joules. Notice that at 32 joules, for it to reach your brain, it'll only, in effect, only provide 4 joules per square centimeters, which is why I keep saying that most likely light-emitting diode arrays probably won't reach brain tissues. These are lasers, 32 joules just to provide 4 joules into your brain. And they noted that low photobiomodulation fluencies of 5 to 10 joules per square centimeter induce relaxation of the mesenteric lymphatics, improving drainage. The word there is mesenteric, mesentery. They applied photobiomodulation in the cranium, and it induced relaxation of the mesentery in your abdomen, which goes towards the point on my previous slide that treatment, if your aim is for neuroprotection, maybe there is a sense in providing treatment in your abdomen, because even in the brain, the effect is on the mesenteric lymphatics, and this improved drainage in the brain itself. Higher fluencies of 30 and 70 joules per square centimeters completely block the contractility of these vessels. Conclusion: emerging evidence suggests that MLVs play a key role in maintaining brain homeostasis by draining macromolecules. Photobiomodulation can stimulate MLVs, which might be one of the mechanisms underlying the positive clinical outcomes. Transcranial photobiomodulation, again using laser, can affect the aqueous component of the CSF and the interstitial fluid, creating a freer flowing slippery effect. Photobiomodulation induced production of nitric oxide can increase overall blood perfusion, and delivery of sufficient light dose to deeper structures in the human brain is still a challenge in the transcranial photobiomodulation field. Hence, one, use of lasers, two, maybe applying it in the abdomen. Which leads me to my next study, Lights at Night. Does photobiomodulation improve sleep? Points to ponder. This study points to the glymphatic system, which drains toxins in your brain, is under circadian control. The glymphatic flow correlates closely with the onset of slow-wave brain activity, characteristic of non-REM sleep or deep sleep. Glymphatic activity reduces considerably or almost stops with the change to the faster wave patterns at the onset of wakefulness and even during dreaming, together with the activation of the ascending neurotransmitter systems. It should be noted the typical wavelengths of light that we use for photobiomodulation, 600 to 1,000 nanometers, has not been shown to suppress the brain release of melatonin. These longer wavelengths have even been suggested to promote the release of melatonin, which can only be of benefit to a night's sleep. Photobiomodulation has been reported to induce sleeping and prolong sleep duration in mice, whereas the use of blue light, which I'll also discuss later, by contrast, has the reverse effect by suppressing melatonin release, and prolonged nighttime exposure results in a poor quality of sleep, which is why a lot of people tell you don't look at your cell phones at night if you want to have good night's sleep. The author suggests that nocturnal photobiomodulation, by stimulating the function of the glymphatic system of the brain at night, will form an effective non-pharmacologic treatment that helps improve the overall quality of sleep and hence well-being. This is the blue light study that I wanted to point to. Exposure to blue LED light while exerting antimicrobial activity on gram-negative and positive bacteria promotes transient EMT light changes in growth arresting keratinocytes or skin cells. We've all been exposed to a lot of these masks that use blue light for quote-unquote skin rejuvenation, whatever, acne treatment. It's been shown that exposure to blue light emitting diodes induced an intense cytocidal or cell-killing activity against gram-positive bacteria, Staphylococcus aureus, and gram-negative like Pseudomonas, associated with catheter-related infections. However, they've also noticed that treatment of blue LED of a human skin cell, keratinocyte cell line, induced a transient cell cycle arrest, and the cells underwent a epithelial to mesenchymal transition, or back to stem cell-like phenotype. A scratch assay performed 24 hours here after blue light LED radiation showed a delay in the migration of blue LED irradiated HACAT cells, with respect to the control group. This is the control group. This is the blue light irradiated cells. Notice that the scratch test did not heal as fast as in the non-treated group. However, full wound closure occurred in both groups after 48 hours. The hypothesized mechanism of the cytotoxic cell effect of blue LED on host cells is similar to that on bacteria, which is associated with the photoexcitation of intracellular chromophores, sensitive to blue light in the subsequent generation of cytotoxic ROS, which falls back to our previous discussion on other light-absorbing molecules and how photobiomodulation in itself probably has more effects rather than just the cytochrome C oxidase theory of cell improvement. The moral of the story is photobiomodulation therapy is never as simple as it seems or is marketed to be, and it should not be treated the same way we operate our microwave ovens. A lot of people tell me they prefer the microwave oven example of having the popcorn and the pizza buttons in there, as opposed to manually programming the microwave oven. If you're trying to cook something in your microwave, it's better for you to manually program it, because it might either turn out to be a cookie if it's a pizza, if you overheat it, or it might be undercooked. There's just a quick rundown of 3 published articles in 2022 referencing BioFlex. We finally have something published, thank God, for the past year. The first one, it was actually published late last year. I didn't include this in last year's webinar because it was released a few weeks after. This is the impact assessment of photobiomodulation therapy for post-concussion syndrome, wherein we've demonstrated that photobiomodulation therapy applied to the cervical spine improved impact scores. Impact is the test that a lot of athletes use as a gauge for return to play decisions. It tests your neurocognitive function, and we've shown in this study that there was improvement in neurocognitive functions after photobiomodulation therapy for patients suffering from post-concussion syndrome. The second article did not come from our clinic, but it came from our friends in McMaster University in Hamilton. And I'm very interested in this study, the modulation of the autonomic nervous system by one session of spinal low-level laser therapy in patients with chronic colonic motility dysfunction. Their main goal of treatment here is to improve constipation in patients. What interested me the most was their application of the treatment in the low back and how it affected the heart rate, how there was a variation in heart rate in patients who were being treated in their lumbar spine. This gave me some thoughts on potential studies that we may be able to use in the future for, say, POTS, postural orthostatic hypotension syndrome, and how it affects this autonomia, which is your autonomic nervous system. The last published report study from our group is photobiomodulation for modulation of neuropathic pain and improvement of scar tissue. It's actually three pathologies that we're dealing here. There was supposed to be an improvement of mood symptoms here, but the editors felt like since we did not do an assessment method of the person's mood before and after, that might not be accurate. But if you'd like to read this article, this is a patient of ours who was suffering from significant post-surgical neuropathic pain after she had a cholecystectomy. For 4 or 5 years, she was in a cocktail of pills, was living with her parents, and her scar tissue from the surgery was keloid producing and was hyperemic. And after treatment, we not only improved the neuropathic pain, we improved the scar tissue, but also her mood disorders. And she's back to work right now. She's a professional working in a university. And this just goes to show the various potential effects of photobiomodulation on various systems here, not just on your epithelial tissue. If you'd like copies of these studies that I've mentioned, feel free to reach out. Join us. Let's explore more stuff. Be another unsexy nerd like me if you have any ideas on any potential studies you'd like to be involved with. And I'd like to quote my mentor. The important thing is not to stop questioning. Curiosity has its own reason for existing. One cannot help but be in awe when one contemplates the mysteries of eternity, of life, of the marvelous structure of reality. It is enough if one tries to comprehend only a little of this mystery every day.
I didn't say that. What are you talking about? Who
That
said
was
that?
Albert Einstein, but since you are
Oh,
my Einstein, David, I put your name here. Okay, so Merry Christmas.
all right. Thanks, Randy. It looks like we went overtime.
I'm sure.
I mean, let me just pull up my. Oh, there's Randy. All right. So before we let everyone go, hopefully you enjoyed today's. There's a question for you, Randy. Are there suggested placements for anxiety, depression disorders?
And yeah, actually, we still do the cervical spine placements. We do have a study protocol that we designed that we're hoping to pursue next year. It's still the cervical spine applications, but we're using more infrared. We're barely using any of the red wavelengths. We're using more infrared. So longer infrared applications.
Right. And then a question, I guess, for me is cortisone shots for the knee in the same category as NSAIDs. Well, they're not the same drug or pathway, but the risk with excessive cortisone shots, if maybe you want to chime in as well, Randy, is that if you have excessive cortisone shots in one area, it can lead to actually degeneration of tissue, and it's not typically done. I don't think they do like too many cortisone shots in the same area because of that.
Because of that, and there actually isn't proof that cortisone shots do all the time help out in osteoarthritis. Plus, there are studies that show that they counteract each other using both cortisone and photobiomodulation because they act on the same, they have the same mechanism of action.
Yeah, Mike Sider that was listening in commented if we have something where there's a monthly email that we summarize the latest research based on keywords that you specify. We're not providing that right now. Maybe that's something that we can do on an ongoing basis because Randy needs to find some more work to do. So maybe I'll get him to do that. But for now, we don't do that,
More
Mike.
work to do. Okay.
Yeah. And then what else? Well, Lauren had a question, but I don't get the question. Was that near infrared instead of red? Oh, yeah. So, yeah, go ahead.
Where's that? For what?
For depression, anxiety.
Yeah, near infrared instead of red. Yeah.
Okay. Please send Ronald's email. I'm interested in getting a copy of post-concussion articles. Just his email is randy@bioflexlaser.com. He prefers what?
Over it's Ronaldo or research@bioflexlaser.com.
Sorry.
It's at the end of my slide. So if you're getting a copy of this presentation,
my bad. No, actually, I did that by mistake. So it's Ronaldo@bioflexlaser.com. You can reach out to Randy. It's confusing, right? But it's Ronaldo at bioflexlaser.com. Mine's David, quite a little bit easier to figure out, at bioflexlaser.com. And the previous slide I had here was, we haven't posted our new events yet, but for anything education-wise, just go to our website, click on education, you'll see the different offerings that we have, including Light Up Your Practice, free webinars, certification training, advanced certification training, and masterclass. And we'll be announcing these events later in December and into January as well, too, if you want to watch those. And I think that's it. Okay, thanks, everyone. Thanks a lot, Randy. Appreciate your time. Take care, everyone.